Chapter 19, Online Lecture. Respiratory defenses. Most common place for infectious agents to gain access to the body is your respiratory system. Nasal hair traps potential pathogens and particles. Cilia traps particles, pathogens, and moves things up and out. This is review, of course. We talked about this a little bit in Unit 3. Mucus traps pathogens. And then, of course, you have your involuntary responses like coughing and sneezing, which move things up and out, and swallowing, that moves things into your acidic stomach. Normal biota of the respiratory tract is generally limited to the upper respiratory tract. Gram-positive bacteria like strep and staph are very common, but there's lots of others. Disease-causing bacteria are present as normal biota. And they can cause disease if their host becomes immunocompromised. So sometimes we have things that can bother us if we're immunocompromised. They gain access to body sites they don't normally have access to, like blood. So, or if they're transferred to other hosts. So there's sometimes the potential there. In addition to normal flora, macrophages are present in the lung tissue, along with secretory IgA in the mucous lining. Rhinitis and sinusitis. These are caused mostly by rhinoviruses. There are 99 recognized types of human rhinoviruses. Symptoms are sneezing, scratchy throat, runny nose, things you think about with a cold. Typically not a fever, or if it is a fever, it's very low. Modes of transmission, aerosols of respiratory droplets, and then of course contaminated surfaces, and even direct person-to-person contact. Sinusitis is generally preceded by a cold. Otitis media, which is ear infection, often follows respiratory infections. It's more common in children because their eustachian tubes are more horizontal, and so it's easier for organisms to collect and cause an infection. Common bacterial causes, Streptococcus pneumoniae and Haemophilus influenza. Viral infections of the upper respiratory tract lead to inflammation of the eustachian tubes and buildup of fluid in the middle ear. They can lead to bacterial multiplication in that fluid, and then, of course, pressure. Chronic otitis media is when fluid remains in the middle ear for indefinite periods of time. You could even have biofilm formation in that fluid, in that area. Symptoms, sensation of fullness or pain in the ear, even loss of hearing. Untreated or severe infections can lead to eardrum rupture from the buildup of pressure and gases. Pharyngitis can be bacterial or viral. You get a reddening of the mucosa, swollen tonsils, maybe little white pockets of inflammation. You can even have swelling of the mucous membranes and tonsils affecting your speech, and then usually some foul-smelling breath from the organisms. All right, so let's talk about Streptococcus pyogenes. Of course, the common cause of pharyngitis, but we're going to move on, and we've mentioned the strep throat before. We're going to talk about some of the complications. Scarlet fever occurs when a bacteriophage in the bacterial genome gives Streptococcus pyogenes an erythrogenic toxin. And then when that happens, you can have scarlet fever. You get a sandpaper-like rash, high fever. It's mostly school-age children. Only some strains possess this toxin. Again, we've talked a little bit about this before. Rheumatic fever, reaction between streptococcal M protein and heart muscle. So streptococcal M protein on the organism, your body creates antibodies to it and they cross-react with heart muscle. It occurs about 3 weeks after pharyngitis has subsided. It does not occur in everyone. But when it does occur, you can have damage to the heart valves, and you can even have arthritis in certain joints. Glomerulonephritis, it's formation of antigen-antibody complexes in the glomeruli of the kidneys. It's characterized by nephritis and inflammation of the kidneys. It does not happen in everyone. Toxic shock syndrome, it's a toxin-mediated life-threatening illness precipitated by infection with Strep pyogenes or even Staph aureus. High fever, rash, multi-organ failure, meaning 3 or more organs. You even have disquamination of the skin on the palms and the soles, so you get peeling. Virulence factors for Strep pyogenes. It's got some surface antigens, lipoteichoic acids. Of course, it's gram-positive, so it has LTA. M protein, we talked about that a second ago, that you can have antibodies formed to that cross-react with heart tissue. Hyaluronic acid, we've talked before about hyaluronic acid as a virulence factor. It does have extracellular toxins, several streptolysins that are responsible for the hemolytic activity that we are familiar with strep pyogenes. An erythrogenic toxin, we said some of the strains have that, and they can cause scarlet fever. Some of the strains have superantigens, and these can induce basically tumor necrosis factor mediated damage and lots of inflammation, and we saw that with toxic shock syndrome. So there is a little bit of review here about what we learned about toxins and strep pyogenes in previous chapters. Transmission and epidemiology. 30% of sore throats are thought to be caused by strep pyogenes. So that means 70% by something else. There are over 80 serotypes of strep pyogenes. If you mount an immune system to one, it usually doesn't cross-protect you against anything else. 15% of the population carries strep pyogenes as part of their normal flora. Humans are the only significant reservoir of Streptococcus pyogenes. Transmission via respiratory droplets, direct contact with mucus secretions, and fomites. Culture and diagnosis. There are rapid diagnostic tests. We learned all about this in lab, so I'm not going to go through it again, but you know about the rapid strep and how it uses antibodies and the possibility for false negatives. If that's not familiar, go back and review that section in lab. And then you can confirm with culturing. When you culture, you plate on sheep's blood agar. You look for hemolysis differences and bacitracin sensitivity. So of course, again, all sort of lab review there. There is treatment. Antibiotics are effective against a strep pyogenes infection, a nice strep throat. Diphtheria. We talked about diphtheria when we learned about exotoxins, so a little bit of review. You should be familiar with this one a little bit already. Corynebacterium diphtheriae. It's a non-spore forming gram-positive rod-shaped organism. It has an exotoxin. It causes necrotic damage and formation of a pseudomembrane. And again, talked about that in Unit 2. The diphtheria exotoxin was encoded by a bacteriophage. If you'll remember back in the virus chapter, bacteriophages are viruses that infect bacteria. So there are viruses that infect bacteria, and in the process, they integrate toxins into their genome, and that's where that toxin came from. Transmission, droplet contact, direct contact, fomites. Prevention is part of the DTaP vaccine series. And treatment, you can give an antitoxin during the infection, but you can also use antibiotic therapy. Whooping cough or pertussis. Bordetella pertussis colonizes the cilia of the mammalian respiratory epithelium. You can see that picture there. You can see the cilia and you also see the bacterial cells. Respiratory droplet transmission. It's a pathogen only for humans but also possibly higher primates. No known other reservoir. It's a mild disease in adults but has a significant mortality rate in infants. The catarrhal stage is after the initial infection. It lasts 1 to 2 weeks. You have bacteria in the respiratory tract, and you have a basic, sort of like a common cold. Antibiotics are effective at this stage because you have lots of bacteria present. The paroxysmal stage is toxin mediated. So your bacterial numbers are low, but you have lots of toxin there left over that was made back when your bacterial numbers were high. So this is the toxin-mediated stage. Antibiotics are ineffective because it's the toxin causing the damage, and the antibiotics will not target the toxin. Severe coughing can result in burst blood vessels in the eyes, vomiting. And then in infants can be fatal. It's followed by a long recovery or convalescent phase that can take months. Tuberculosis, caused by Mycobacterium tuberculosis. We're familiar with this guy when we learned about acid-fast bacteria and the mycolic acids. Droplet transmission from respiratory mucus. It can survive for up to 8 months in fine aerosol particles, so it can hang out for a long time. Susceptibility is influenced by inadequate nutrition, debilitation of your immune system, poor access to medical care. If you have previous lung damage, there even might be a genetic component. It's estimated that 2 billion people are currently infected with tuberculosis. Just for Comparison, the world population is about 8 billion, so 25% of the population of the Earth. 60% of the U.S. cases are among foreign-born persons from Mexico, Philippines, Vietnam, India, and China. TB infection versus disease. TB infection is not the same as TB disease. These are separate. TB infection means that Mycobacterium tuberculosis is in the body, but the immune system's keeping it at bay. Mycobacterium tuberculosis typically infects the lungs. It can also spread to other parts of the body, like the kidney, the spine, the brain. When you have TB infection but you do not have TB disease, the person is not infectious. They cannot spread it. They will have a positive PPD skin test, but their chest x-ray will be normal. All right, so with tuberculosis, humans are easily infected with Mycobacterium tuberculosis, but they are fairly resistant to disease. Only about 5% of infected people will develop clinical case of tuberculosis, so 95% will not. Untreated tuberculosis progresses slowly, and it can take a long time before they realize they have more than just respiratory cold as it becomes more severe. Clinical TB is divided into primary, secondary, and disseminated tuberculosis. Primary tuberculosis. It only takes about 10 bacterial cells to cause an infection, so not many at all. The bacteria multiply inside alveolar macrophages, so that's why it's hard for the immune system to attack this, because it lives inside macrophages. Tubercules form. These are small nodular lesions in the lungs. The bacteria can hide out around there. The centers of the tubercules can break down into necrotic lesions, and they heal by calcification. When these contain immune cells that help to wall off bacteria inside the lesion, then they're known as granulomas. I'll show this on the next picture. These are viewable in a chest x-ray. Here's a picture of the tubercle. You got granuloma. It's a granuloma formed because it's surrounded by immune cells that are trying to keep everything inside. At the very center of this would be mycobacterium cells, living cells. And so in some people, these lesions can keep the organisms walled off in their lungs for a lifetime. And in other individuals, these break down and release bacteria back into the body. All right, secondary or reactivation tuberculosis. So live bacteria can remain dormant in the body and become reactivated weeks or years later, or never at all. Tubercules fill with bacteria, expand and drain into bronchial tubes in the upper respiratory tract. Violent coughing, greenish or bloody sputum, anorexia, weight loss, fatigue, chest pain. Disseminated tuberculosis. Miliary TB is where it disseminates through the body, and you actually see a seed pattern on an x-ray. When it spreads from the lungs to other parts of the body, so it's shown there in that little girl's neck, it's more common in immunosuppressed people and young children. There is a vaccine, the BCG vaccine. It's made from an attenuated or weakened Mycobacterium bovis strain. It's a bovine strain. The World Health Organization recommends this in endemic countries where there is a lot of tuberculosis. Effective against TB-derived meningitis and miliary TB. So it can help prevent that dissemination, and it can help prevent the complication of meningitis. It has variable effectiveness against adult pulmonary tuberculosis. In the U.S., we mostly see pulmonary tuberculosis, so the vaccine wouldn't be very effective. Additionally, the vaccine interferes with the PPD skin test, which is another reason why we do not use it here in the U.S. The PPD skin test, it's to determine if a person's infected with Mycobacterium tuberculosis. After exposure, your immune system reacts specifically to the presence of Mycobacterium tuberculosis in your body. This does take a couple weeks. The PPD test measures a secondary reaction to Mycobacterium tuberculosis protein exposure. And if you go back to Unit 3 and review the idea of a primary and secondary immune response. For the procedure, intradermal injection of purified tuberculin protein is put under the skin. If you have a secondary immune response, your reaction is going to be much quicker and much stronger, and you will get a very large red induration. And that's what they measure. They measure the induration 24 to 48 hours later, and depending on the size of that induration, it will say whether or not you're having a secondary immune response. A positive reaction is always followed up with a chest x-ray because, again, you can be infected without having tuberculosis disease. Pneumonia. an inflammatory condition of the lungs in which fluid fills the alveoli. It can be caused by a wide variety of microbes. Viral pneumonias are usually milder than bacterial. Begins with upper respiratory tract symptoms, including runny nose and congestion. Fever is often present. And then also you have chest pain, fever, greeny yellow sputum. Streptococcus pneumoniae causes pneumonia. It's known as pneumococcus. It's the most common cause of bacterial pneumonia. The capsule is the main virulence factor. It aids in the evasion of the immune system. There is a vaccine to protect against several common strains of Streptococcus pneumoniae. It targets the pneumococcal polysaccharide capsule. And there's a version for adults and another version for children. Legionella pneumophilia. It's found naturally in water supplies. It's an intracellular bacteria that resides inside host macrophages, like those pulmonary alveolar macrophages. Antibiotics are not overly effective because this guy likes to hang out inside host cells. The disease is legionosis. There's Legionnaire's disease, typically leads to pneumonia, which can be fatal. And then there's also Pontiac fever. It's a milder disease with similar symptoms, but without the development of pneumonia, and it resolves much quicker. Diagnosis. Chest x-ray for diagnosis of pneumonia, but you can also isolate bacteria from the sputum to determine the cause of pneumonia. Transmission from aerosols, breathing in contaminated mist or vapor, so like a steam room or hotel air conditioner vapors. It's common to see outbreaks in hotels and on cruise ships because their large AC cooling tanks become contaminated, or if their large AC cooling tanks become contaminated. The bacteria does not multiply well in small water sources like in your home air conditioner unit. It's not spread person to person. Klebsiella pneumoniae, gram-negative capsule, has a capsule, found on the skin, pharynx, and GI tract, and we talked about this a little bit in lab. Severe nosocomial infection with necrosis, inflammation, and hemorrhaging of the lungs. We talked about that current gel sputum in lab as well. Who's at risk? Well, not typically healthy individuals, but people with having respiratory interventions like ventilators, people on long-term antibiotics, the immunocompromised in a nosocomial setting. Transmission, person to person or contamination of the environment. It's not airborne, but it can be passed from respiratory secretions. Diagnosis and treatment. X-rays and symptoms, of course, that current jelly sputum. Even with antibiotic treatment, it's got about a 50% mortality rate, and some strains have become highly resistant to antibiotics, which is of great concern in a hospital setting. That's the end of the Chapter 19 lecture.